ASMR anatomy series. In this video, we're going to pick up where we left off in the heart. So you could say that this is the heart part 2. Last time we closed the video by talking about the surfaces and chambers of the heart. And this time, we are going to start off by talking about the heart valves. So, without further ado, we'll go ahead and get into it. It says that the cardiac valves are divided into two groups, semilunar and atrioventricular. The two semilunar valves, the aortic and pulmonary, are located at the base at the two great arteries that regulate the passage of blood flow from the ventricles to the aorta and the pulmonary trunk. The two atrioventricular valves, left and right, lie at the interface between the atria and the ventricles. So, we're looking here at the plane of the cardiac valves, a superior view looking down into it, and removed are the atria and the great arteries. Okay. So we'll start up here with the pulmonary valve. We've got the right cusp, the left cusp, and the anterior cusp of the pulmonary valve. And then for the aortic valve, we've got the left cusp, the right cusp, and the posterior cusp. So we've got an anterior and a posterior for each of these respective valves, but then a left and right on both. The right coronary artery runs over here. The left coronary artery runs over here. And those are providing oxygenated blood to the heart muscle itself. And then we've got the anterior cusp up here on both sides. Posterior cusp on both sides, and that's going to be for these the ventricles here, because again the atria have been removed and the atria sit on top of the ventricles. So the left atrioventricular or bicuspid or mitral valve, that's what these portions make up, and then the right atrioventricular tricuspid valve. So it's referred to by two different names, bicuspid or mitral. So if you hear somebody say mitral valve, it's the same thing as bicuspid. And the reason that it's called bicuspid is because it has two cusps, 1 and 2. And then this is called tricuspid because it has three cusps, 1, 2, and 3. So just like bicycle and tricycle, bi meaning 2, tri meaning 3. And then we've got the ventricular diastole, which is the relaxation of the ventricles. And that's what we're looking at here in this picture. So it's a relaxation of the ventricles. And the semilunar valves are going to be closed, and the atrioventricular valves are going to be opened. Again, the aortic valve, the left, right, posterior, the pulmonary valve, the left, right, and anterior, the arteries, the tricuspid, and the bicuspid. And you can see how these two cusps here close shut, and these three cusps here close shut to prevent the backflow of blood back into the ventricles when it should be going out. And then we've got ventricular systole here. It's a contraction of the ventricles, and the atrioventricular valves are closed. So I'm realizing this here, I'm sorry. This was diastole, the relaxation because they're open. And then this is systole because they're closed. Sorry, I thought that this was describing this for a second. Forgive me. Alright, and then we've got the position and auscultation sites of the cardiac valves. Auscultation is a very fancy medical term that's used just to describe the action that's taking place. So if you've ever been in your doctor's office and they hold their stethoscope up to your chest and they tell you to take a deep breath, and they're listening to your heart, they're listening to your lungs, that's the practice of auscultation. They're listening to different functioning, different functions of each organ system. And we'll go ahead and go over C, and then we'll go over the position and auscultation sites. the superior view, the cardiac skeleton is formed by dense fibrous connective tissue. The fibrous annuli or rings and intervening trigones separate the atria from the ventricles. This provides mechanical stability, electrical insulation, and an attachment point for the cardiac muscles and valve cusps. So, very, very important and multifunctional connective tissue here. And if you take this and you can overlay it onto here, so that's all this is. So this would lay right over the pulmonary valve. This would lay right over the aortic valve. This would lay right over the right ventricle, or actually this would be, yeah, it separates the atria from the ventricles, so it would be at the base of the atria and laying right on top of the ventricles. And then the left fibrous annulus. And then we've got this right fibrous trigony, which is called that because it's a juncture point for all three, right here, these three features. And then a tendon of conus right here. And we'll get over to the auscultation position and auscultation sites here. So the aortic valve, the anatomical projection, is the left sternal border at the level of the third rib. And then for the aortic valve, the auscultation site is the right second intercostal space at the sternal margin. For the pulmonary valve, the anatomical projection is the left sternal border at the level of the third costal cartilage. And this can be auscultated at the left second intercostal space. The left atrioventricular valve, it can be, the projection is going to be at the left fourth and fifth costal cartilage. And the auscultation site is going to be the left fifth intercostal space at the midclavicular line, or the cardiac apex. We've got the right atrioventricular valve. It's at the sternum at the level of the fifth costal cartilage. And then the left fifth intercostal space at the sternal margin. And now we've got these semilunar valves. These valves have been longitudinally sectioned and opened. Okay? So we've got the ascending aorta here. The opening of the right coronary artery can be seen here. Here's the aortic sinus and the right cusp. So again, longitudinally it's cut down the middle, or down the side here. We've got a nodule here and a lunule here, which is a feature of the cusp itself. The opening of the left coronary artery, and then the left cusp. The posterior papillary muscles. The papillary muscles are those that are responsible for the opening, and when they are in action, they pull the valve open, and when they are not in action, they relax and allow it to close. So that's the function of these papillary muscles. So these muscles are really, really putting in overtime for you. And then we've got the atrioventricular valves. This is an anterior view during ventricular systole. So again, systole is during contraction. So these are, and as you can see, they're closed. They're closed. This is called the commissural cusp. And then we're in the left atrium here, which is shown. So this is where we're at right here. Just if anybody needs help being oriented. And we're looking down, or it's really cut down the side, so this is cut in half, and we're looking at the side of it. We got the anterior cusp here. Did I misspeak? Let me see. This is a tricuspid, so we're on this side. It looks like this, or the orientation of this is changed, or it's a little bit different. Sorry about that. We've got the interatrial septum and the membranous portion here. So we've got a membranous and a muscular portion of the interventricular septum, and that septum is what separates those two features. We've got the tendinous cords, again those papillary muscles, and then the anterior papillary muscles and the cardiac apex, which, if you remember from last time, is the point on the heart, that apex. And then we are in the this time, so we are right here, but we're looking at it from the side. So the opening for the right pulmonary artery, the nodule, a nodule again, pulmonary trunk, the lunule, and then we got the left cusp and the right cusp, and the anterior cusp. So just another look at this, cut from the side and then looking into it, and then the trabecular coronae, basically another muscular feature that's somewhat similar to the papillary muscles. And then we've got the left atrioventricular valve. So we've got the anterior cusp and the septal cusp and the posterior cusp, tendinous cords and the posterior papillary muscles, the septal papillary muscles, the interventricular septum, which is called that because it lies right between the two ventricles, separates the right and the left, and then the septum marginal trabeculae. We've got a clinical box right down here, a clinical box. Clinical box. 9.2, auscultation of the cardiac valves. Heart sounds produced by the closure of the semilunar and atrioventricular valves are carried by the blood flowing through the valve. The resulting sounds are therefore best heard downstream at a defined auscultation site, or the dark circles in the diagram. Valvular heart disease causes turbulent blood flow through the valve, which causes a murmur that be detected at the region of auscultation. So what it's saying here is that you can detect the aortic valve by listening here. You can detect the pulmonary valve by listening here. You can detect the left atrioventricular valve by listening here, and the right atrioventricular valve by listening here. And again, that's basically what this chart over here was saying, but in a clinical form, and some people are more picture than they are, they're more visual than they are auditory. I had to think about that for a second. Alright, let's continue. Arteries and veins of the heart. The coronary arteries and the cardiac veins. So the main functions of these arteries and veins is to support the heart. That's it. And of course, we've got the major features that we will point out just so that we are well oriented. Of course, the superior vena cava, the pulmonary valve, we've got superior left pulmonary vein, and the atrial branches, I think it's coming off of the coronary artery. Here's the left auricle, atrial appendage. Yeah, there's the left coronary artery, so coming off of that. We've got the circumflex branch here, the left marginal artery and vein, the great cardiac vein. So this is basically, trying to think of a way to describe it. It's basically the vena cava of the heart. It's the major venous structure on the heart. And then the anterior interventricular, or also known as the left anterior descending. Now the unfortunate thing about this artery is that it's often known by another name, and that is, it's sometimes called the widowmaker. And the reason that's called that is because it's such an important vascular structure that if it experiences a blockage and you have a heart attack courtesy of a blockage in the left anterior descending artery, you're pretty likely to die. Not 100%, but your chances aren't looking great. So it unfortunately is often called the widowmaker. We've got the lateral branch coming off of that. This is telling us that this is the left ventricle over here and the right ventricle over here. And so the LAD, left anterior descending, or aka the anterior interventricular, it's right on that septum, running right on that septum between the right and the left ventricles. Here's the apex. Here's the anterior veins of the right ventricle, the small cardiac veins, the right marginal artery and veins. Here's the right auricle, the atrial appendage, and then the conus branches and the atrial branches. And then we're looking at a posterior inferior view. So we're on the back and we're slightly below up in, trying to prevent the sunlight from coming in too. The right and left coronary arteries typically anastomose posteriorly at the left atrium and ventricle, and as you remember from what we talked about before, that word anastomose, it just basically means that they come together and they kind of congregate together. It's an intersection. So we've got atrial branches of the arteries. Here's the left atrium, in case you were kind of lost as to where we are. Branches to the sinoatrial node, right pulmonary veins. There's that coronary sinus again. Actually, this is the major venous structure on the front, and this is the major venous structure on the back. The coronary sinus is this is the example I meant to draw. So this is like the superior vena cava on the front of the heart, and this is like the inferior vena cava on the back of the heart, which ironically feeds to the inferior vena cava. We've got the oblique of the left atrium, the great cardiac vein, the circumflex branches, and the left marginal vein, the left posterior ventricular veins, the right posterior lateral arteries, and then the posterior interventricular arteries, posterior descending, small cardiac veins, right coronary artery. So let's get into some of the branches here. Of the left coronary artery, we've got the circumflex branch, which feeds the atrial, left marginal, and posterior left ventricular. We've got the anterior interventricular branches, or the LAD, which also feeds the conus branches, the lateral branches, and the interventricular septal branches. And the right coronary artery has branches to the SA node, to the conus branches, to the atrial branches, to the right marginal branches. And then it also has posterior interventricular branches and interventricular septal branches. Branches to the AV node and to the posterior lateral arteries. And these nodes are conduction features that we'll talk about whenever we get to the venous portion of it all. Or, excuse me, not the venous, the nervous, the electrical conduction portion. Alright, divisions of the cardiac veins. We've got the anterior cardiac veins, which are not shown, drains to the right atrium. We've got the great cardiac veins with tributaries of the anterior ventricular, left marginal, and oblique, which all go to the coronary sinus. So that's that major venous structure here. Left posterior ventricular veins, middle cardiac veins, and small cardiac veins, with branches being the anterior veins of the right ventricle and the right marginal, all going back to that coronary sinus. So the distribution of the coronary arteries. Anterior and posterior views of the heart with superior views of transverse sections through the ventricles. So we've got a front view, a back view, and a top-down view. But the term dominance refers to the artery that gives rise to the posterior interventricular artery as seen in the anterior and posterior views. Right coronary arteries and branches are in green, and left coronary artery and branches are in red. So there's a left coronary dominance here, and the reason that this is important is because it has, it can tell us what vasculature is affected based on, or what muscular feature is it? No, I was right. What vasculature is affected based on the damage that we see in muscle in the event of a blockage. So if you see a part of the heart that's not working correctly, you can pretty quickly rule in or rule out a blockage in a specific arterial portion, because that lack of action or function will tell you, oh, hey, there's an issue here, so it's not working correctly because of this. So it helps them enhance their differential diagnoses. So the left coronary dominance, 15 to 17%. There's a balanced distribution here with the right coronary dominance of 67 to 70%. And then a balanced distribution, a right coronary artery dominance of 67. Or no, that's going to be left coronary dominance here, right coronary artery dominance here. So here, and then right coronary dominance is here. you see a problem with the heart here, that indicates a problem with the blood flow here. So I guess another analogy that could be drawn for it would be the idea of if you see that there is a lack of water going to a part of a farm, and that the crops on that farm start to dry up in that place, you know that there's an issue upriver from whatever feeds that portion of the farm. Whereas if other areas are okay, then you know that the problem isn't upriver from wherever those are. So hopefully that analogy makes sense. But disturbed coronary blood flow, although the coronary arteries are connected by structural anastomoses, they are end arteries from a functional standpoint. The most frequent cause of deficient blood flow is atherosclerosis, a narrowing of the coronary lumen due to plaque-like deposits on the vessel wall. When the decrease in luminal size or stenosis reaches a critical point, coronary blood flow is restricted, causing chest pain or angina pectoris. Initially, this pain is induced by physical effort, but eventually it persists at rest, often radiating to characteristic sites. Example given: medial left upper limb or the left side of the head and neck. If you know anybody who's experiencing pain in those places out of nowhere, not after a workout, not after any kind of exertion, they need to seek medical attention immediately. A myocardial infarction or a heart attack occurs when deficient blood supply causes myocardial tissue to die or experience necrosis. The location and the extent of the infarction depends on the stenosed vessel, and there's a few different instances that they highlight here, A through E. So a apical anterior infarction, you would have issues here. An apical anterior infarction, you would have deficient blood flow impacted in this area of the heart. Anterior lateral infarction is going to be in this location here, right near the apex. Posterior lateral infarction is going to be on the back side of the heart, on the lateral side, well named. And then just a posterior infarction is going to be on the back of the heart. Alright, so we've got the conduction and the innervation of the heart. The contraction of cardiac muscle is modulated by the cardiac conduction system. This system of specialized myocardial cells, also known as Purkinje fibers, generates and conducts excitatory impulses in the heart. The conduction system contains two nodes, both located in the right atrium: the sinoatrial node, or SA node, known as the pacemaker, and the atrioventricular node, or the AV node. And so, with this being called the pacemaker, what you can immediately infer from that is if you know somebody who has a pacemaker, it means that they are experiencing a failure in their SA node. And so the pacemaker is put in to fire off those electrical impulses to replace the lack of function from their the SA node that they were born with. So just a little fun fact for you there. Alright, so there's that SA node right here. And then it has anterior, middle, and internodal bundles that go down to the AV node. And here's an intraatrial bundle. And then, let's see where this is pointing to right here. The atrioventricular bundle of his. The left ventricular bundle, the right ventricular bundle, and then those both lie within the intraventricular septum. So, makes a lot of sense there. Alright, let's look here from a different vantage point. So the heart has been slightly rotated. We can still see the SA node. We can still see the bundle of His. Here are those Purkinje fibers, which we can see a little bit more in greater detail. And then those Purkinje fibers lie kind of interwoven amongst the septomarginal trabeculae. So those cardiac muscles that we talked a little bit earlier, they're being called to action by these Purkinje fibers, which makes sense. It's kind of the same idea as a nerve running through muscle in your arm, and whenever that nerve fires, causes the muscle to fire. But this is involuntary course, is voluntary whenever you decide you want to move some muscles in your arm. Alright, so we've got an anterior view, and all four chambers are opened here. So we can see the left atrium and the left ventricle. Here's the apex. Here's the septum. And then we've got the subendocardial branches of those Purkinje fibers. So just a different viewpoint there. Alright, we've got another clinical box down here. It's an ECG. The cardiac impulse, a physical dipole, travels across the heart and may be detected with electrodes. The use of 3 electrodes that separately record electrical activity of the heart along 3 axes or vectors, Einthoven limb leads, generates an electrical cardiogram, or ECG. The ECG graphs the cardiac cycle or heartbeat, reducing it into a series of waves, segments, and intervals. These ECG components can be used to determine whether cardiac impulses are normal or abnormal, meaning mainly is there a heart attack or is there an enlargement of the heart. Although only 3 leads are required, a standard ECG examination includes at least 2 others, those being the Goldberger and the Wilson leads. So the lead vectors in Einthoven's triangle here, and then recording electrodes here, here, and here. So it's creating kind of it's triangulating basically the waves of your heart. And the features that are being measured on the ECG are features called the P wave, the Q wave, the R wave, the S wave, and the T wave. And there's the ST segment right here. So it's the portion going from the S to the T called the ST segment. And there's a thing here where if you see a jump in the ST segment, they'll call it a STEMI, S-T-E-M-I. And what that means is ST segment, ST, that's the ST of STEMI, elevation, S-T-E-M-I, myocardial infarction. So they're saying that they can see, that they know that there's a heart attack taking place because of an elevation in the ST segment. So STEMI, S-T-E-M-I, ST segment elevated myocardial infarction. We'll continue with the innervation and pre- and postnatal circulation. We'll continue that in the heart part 3. I think we'll do a heart part 3, and then we'll move on to other features within the mediastinum, because I don't want this to be too long of a video. So it's been cool to go through the arteries and veins of the heart, and the valves, and then the conduction. We'll go through the remainder of the conduction. We'll go through prenatal and postnatal circulation, and then I think we'll continue on with features like the esophagus and other things like that as we continue through the mediastinum and the thorax. So if you stuck with me to this point in the video, thank you for watching. If you're not subscribed yet and you watched this far, please do. And if you like this video and you want to see more like it, please leave a like. That allows people like me to continue to make videos for people like you to enjoy. Hopefully this has been relaxing and educational. And if you were using it to sleep,